Wilma, Alvarado, the floor is yours again. Thank you.
Okay, you're sure. No, no worries. So I'll share an example of some of what had come across from our guidance. And the one of the projects that we're involved in is the governor's Ask a Question web form. And what that means is that there is on our website a link where any New Yorker, basically anybody, can ask any questions about the pandemic. And so we work with the Executive Chamber Department of Health to break a lot of this down. And so when we had new guidance before, it was it talked about, a rolling average, whatever, with data collected on various levels and areas. So what our guidance said is, Governor Andrew Cuomo has announced new guidelines allowing travelers to New York to test out, quote unquote, the mandatory 14-day quarantine. Travelers that are from contiguous states with New York are exempt from the travel advisory. However, covered travelers must continue to fill out the travel health form. And so it says for travelers who are out of state for more than 24 hours, they must obtain a test within 3 days of departure prior to arrival to New York. They must, upon arrival in New York, quarantine for 3 days. On the fourth day of their quarantine, they must obtain another COVID test. If both tests are negative, the traveler may exit quarantine upon early receipt of the second negative diagnostic test. So this is a lot of information. So what we did was we boiled down the language so that it would be a lot easier, we hope, to respond, because through the governor's Ask a Question web form, people are asking us, I'm confused, what do I need to do? So what we boiled it down to was, okay, in an effort to limit the spread of COVID-19, all non-essential travel to New York should be postponed. Essential workers will continue to be exempt as well and must fill out the traveler health form. So people at this point know what an essential worker is and who isn't, right? So we share with them that all adults and children who are traveling to New York after spending more than 24 hours in one of these following locations, you need to do the following. So if you do these three things, if you were somewhere more than 24 hours, if you're in a state that does not border New York, is a U.S. territory, or it's a level 2 or a level 3 country, you need to complete a travel health form, and you need to quarantine for 14 days upon arrival. That's the guidance boiled down, okay? Then we said, or you can also do this: submit a travel health form, obtain either a rapid test or a test performed by a clinical lab no more than 3 days prior to your arrival in New York, because the guidance had said you get tested. And then people were like, well, what kind of test do I have to have, right? And so then we say, after 3 days of arriving to New York, on the fourth day, you have to take a second test, okay? And then you remain quarantined until negative results for both tests are received. So there you go. Before you come to New York, you take your test within 3 days. You land, you quarantine for 3 days. On your fourth day here, you take your next test, okay? Both tests are negative, you're free to go about your travel. So we broke this down because folks are getting really overwhelmed and just really confused. And then, then you get sometimes the danger with this is sometimes you get some really nuanced questions like, well, if I happen to be coming from, if I'm only flying into JFK and I have a connecting flight, do I have to quarantine? Well, no, you're passing through, so that's also in the guidance, so there's no need to quarantine. However, being mindful of some of the other pieces that are involved in travel, the guidance does explain that because there's also an FAQ attached. So again, sometimes folks are in a little bit of overwhelm, so they're not really focusing on everything, so it's our responsibility to provide that information as clearly as we can. So we were getting questions specifically about the testing. So originally the language said travelers will have needed to have been tested within 72 hours of coming to New York State. Since short-time visitors will not be here on day 4 and can't be tested, they must quarantine. So we didn't think that language was clear enough. So we said, travelers to New York need to be tested within 72 hours of arrival, and again on the 4th day of their stay. Visitors in New York less than 4 days must quarantine their entire stay. So people will hear, if you're here less than 4 days, then guess what? You have to quarantine. So this was a lot of the information that we've had to work around. And then this is English to English. So adding a cultural and linguistic layer to this makes it a little bit more complex. Folks have to travel for different reasons. And our role is to point to the guidance and to provide the information. Sometimes we do get questions where it sounds more like folks are asking for permission, and we have to be very careful because we respond via email, and sometimes email can take on a life of its own. So we have to be very careful on how we're responding to some of these things. So it's been an interesting process looking at some of the language and how to use that plain language and health literacy lens in the communication that we provide directly to responses received from folks from basically anywhere. So that's a little bit of what we've had to do. We've also been involved with working with our vulnerable communities. COVID has been the equalizer. It has really brought racial and ethnic inequities to the forefront. And so we have been working diligently in seeing how we can best address the information to get this out to our communities. And so as a matter of fact, I'm working with the contact tracers specifically on health literacy. And some folks are talking about, the cultural component to this. And I said, well, that's a whole other conversation because, this isn't the time to read a book or see a movie. People should have done that, because while people are learning, our communities are dying. So we need to be able to communicate things in a way that is extremely efficient and clear, and also create that space so that folks feel that they can ask the question. And so this is some of what we're going to be doing with our contact tracers. What is going on from a health literacy perspective that we need to do and build on to encourage providing information and obtaining information that's going to be protecting our communities. So no shortage of work to be done here. I'll pause now, and I'm looking at the time in case there's any questions. All right, so everyone's on mute, or I answered everybody's question, or both?
Well, Wilma, this is Cynthia Bauer. So I know Greg had asked me to facilitate the Q&A, so maybe I'll jump in here now.
Sure.
And I wanted to have you kind of take a step back. I mean, given the responsibilities of your office to focus on health disparity prevention, the student team that you're speaking with today, as well as some of the other attendees, one of the things they're doing is, one of the main things they're doing is they're taking a look at their own training and education within the various disciplines they represent, which are all the health sciences plus social work and law and public health. And they are going to be making recommendations to Dr. Jarrell and his team, as well as to the president of our College Park University, which is where the School of Public Health is, about how to think, in a broad way across a very big institution. So do you have any advice for our students given the charge that Howard Zucker gave you to think about infusing health literacy across the New York State Department of Health? What advice would you have for our students in thinking about infusing health literacy through their own educational experience across all of these schools that they represent, medicine, nursing, dentistry, law, public health? Any advice for them as they think about the recommendations to make to Dr. Jarrell and his team and Dr. Pines and his team down at our College Park campus?
Well, each one of those, has its own culture, so, being an MSW myself, we have our own culture. We think about how are we going to, it's all about the client, right? And so how do we address their concerns during that time? And then each one, for example, our School of Public Health, I'll use ours as an example. It's a lot. We're fortunate that there is a big emphasis on health literacy throughout that school, and also with leadership. And then within here, we're here in the tower. I'll have a question. So there was, for example, going back to the guidance, there was something that said, you have to do this, that, and the other if you're traveling, and this guidance applies to all covered travelers. So I asked my colleague, we're all senior staff, so I asked my colleagues, what's the definition of a covered traveler? And so that email ended up to having, because I said, okay, so I asked this during a senior staff meeting, and I said, I just want to put out there for consideration, because I understand that there has to be legal language utilized, right? And I said, so I just want to put out there that for consideration that when people are traveling, they're packing their bags, they're trying to get from point A to point B, they're not going to really think about what a covered traveler means. They're just going to think, okay, if you're traveling, and then that's it. Well, yeah, we're close. And so there wasn't consensus reached. We had people nodding. So then I put it in an email, and I said, I'm following up. I don't believe we reached consensus on the definition of what is a covered traveler. We're getting inquiries asking this. So that email thread evolved to a few people, so that we were all on the same page, because it's like, the parable of the 7 blind men all touching different parts of the elephant. And they each had a description for each part of that elephant, and they were each correct. However, you're looking at it through a different lens and a different experience. So one of the first things I would say is, who's your audience? That was my experience here in the tower. I needed to know who was going to be looking at it in what way, and what was their objective, right? So were the nutrition people looking at it from one way? The data folks were looking at it in another way. Our office was looking at it in one way. So what did health literacy mean to all these other folks? And so we're all trying to move in the same direction. We may be taking different paths. So what is the intention and the purpose of utilizing health literacy, and what is your expected outcome? So that would be one of my first asks to find out. And what resources are currently available? That was the purpose of doing the survey, because people thought that they had these resources that could be helpful, and quite honestly, it was sometimes a situation where folks knew just enough to be dangerous, and what was the correct utilization of tools. So there's some tools that weren't really meant to, assess a literacy level on a website. And so were folks using something that they thought was applicable, and maybe not utilizing a tool that may have been the best fit? So seeing what resources are currently available, and then also did the organization have a definition of health literacy that they were using? And if so, how did that come about? And if not, what do we need to get there to have a definition of health literacy? So these are all the really basic pieces that aren't really basic. They're the foundation of the work that you're going to be building on. And so what is helpful to that end user? What resources are currently available? What resources should people have? What is the timeline to get all this up and moving? And then also too, how are we going to reach consensus on some of this? So I would look at some of these pieces first that has served us well in moving forward. And then also too, depending on the audience, there's a certain register that is going to have to be used. And so, is there common agreement with that as well? Because everybody at some point is going to cross into some of these other areas, and is it going to make sense? For myself, it was helpful to have a multidisciplinary approach to finding out what was going to be the most helpful, because we deal with so many different aspects of health, and at the end of the day, it's our responsibility to do the best we can for those whom we serve.
So I know Dr. Gerald has a question. Dr. Gerald, you want to go next?
Thank you, Dr. Bauer. Yeah. The question I have is we're now looking at vaccines coming into the market here. And there's a lot of groups who have opinions about this. There's certainly a broad representation of different language being spoken, different ethnic groups, et cetera. So how do we communicate? Well, I have to go back up one step and say, assuming that people on the call agree that vaccines are protective and useful, how do we communicate that in a responsible health literacy manner?
Oh, that's a great question, because that's one of the things that we're working on here. Our commissioner, part of our legislation is to have a minority health council, and that council is made up of representatives from across the state who are really the boots on the ground. And so they are Senate vetted and then governor appointed, and they're the advisory group to our commissioner for the state health department. And so what we did was we went to them and I said, if we had to, and when that moment comes, because at the time we were looking at a second wave, who in the community could you go to say, how can you help us? And how can you help us? So would they be available? Would it be a CBO that could put up a pop-up testing site? Would it be a spiritual community that could disseminate information? Because there's a lot of historical trauma, right? And we're looking at it from a trauma-informed perspective. And so when I say trauma-informed, it's, not the thinking of, why did you do that? But more so, what happened to you? That's resulting in an action. So having that trauma-informed perspective is one of the things that I'm strongly advocating be part of the work that we do. Because, we'll have, say, for example, tomorrow you have all the vaccines available for everyone, and there's still a level of distrust in the community, even though it's available, right? And not that because something's available, it's accessible. That's another piece to this. But say, for example, you do have this, is the community going to be trusting enough? And if not, why not? So that's one of the steps that we're working on right now, going through our the members in the community who are trusted, who can support the work that we're doing. So when we went to our Minority Health Council and we asked, who are your partners that would be available to support this, please provide that information. So the communities may trust us because a trusted member of their community is a liaison. So that's one of the approaches that we're doing. The other is we're in the process of putting together some listening sessions to include the communities, and of course they would have to be done virtually. And then again, because they're being done virtually, that's going to include the population that has access to the internet and the time to be able to be on, a group chat, if you will, to find out what can we do if there's something that we aren't doing, and what are we missing? Because as one of our council members has said, just because it's available doesn't mean that people are going to have that buy-in. And that's the part that we have to really work on and look at it from that lens, from that trauma-informed care. Because people still are remembering Tuskegee. They're remembering, HeLa cells, and now that it's come to the forefront that that what happened in Tuskegee also happened in Guatemala, also happened in Puerto Rico. Puerto Rico also had, this, forced sterilization. So we're going to need to approach with caution. And those of us who are of color, who are a bridge between two worlds, the community remembers, like they'll look at me and know that, I'm a Latina, however, I'm part of the state. So what's going to be my role and my message as I move forward? So it's complex. However, it's the verbal and nonverbal communication on how we're connecting with our community.
Have you heard, if I can follow up on your question, Dr. Gerald, Wilma, have you heard anything from your minority council yet in terms of how? Are there any messages that have been working or things that approaches? So once you've made that connection with the trusted community members, which, you know, Baltimore, the campus in Baltimore, which is where most of the people on this call are from, you know, they do have a number of entities and a number of connections into the community. Once you have those kind of trusted connections, is there anything you're hearing that can be said or the framing of that information or those messages that will help, you know, take that next step?
Well, right now, and it's really interesting because I've had like conversations about this on Wednesday, last Wednesday. First of all, they want to know what the role of this office is, right? Because we've been that bridge to the community in many ways. And so that's one thing. And what we're hearing is that first and foremost, people want to be heard. So if, you know, they're not at the point right now of this really worked, because it's my understanding from the community that I've spoken with, the community is still trying to get their head around what does this vaccine mean and who's going to be getting it. Is it an issue of empowerment, disempowerment? Is it an issue of, you know, politics? Because unfortunately, all of this has been politicized. You know, at one point, you know, our communities thought that only white people were getting COVID because they were the only ones in the news, right? And so we have to be really careful and how we respond. So hence the reason for going back out to our communities who are first asking us, well, how are you involved? Are you involved? Because how are you involved? And I take that as a positive because they've trusted us in the past. So I've taken that to some folks here at DOH to say, okay, we have, you know, there's a vaccine plan that's public, and there's representation from various areas of the community. However, they're not representing all New Yorkers. So how can we find another opportunity to get that voice? And that's where we're hoping we hear a little bit more. Right now, from my experience, I'm not speaking for all of DOH here, not in any way, shape, or form. My experience is that people are still trying to get their head wrapped around who's getting the vaccine, why is that group getting it, and then how are we going to be able to get it when it's our turn to have it offered to us.
So Greg, I want to check with you. Are you unmuting the fellows to ask their own questions, or do you want them emailing their questions to me? I don't see an answer from Greg, so I will go ahead and pose Sonia's question, which she had sent me in the chat. She wanted to know, what do you see are the crucial health literacy issues that are still, you know, embedded in contact tracing, which you mentioned, and also in the vaccines, especially for people with limited English proficiency, given your history of working on some of these issues? And then specifically, how can healthcare providers play a role in encouraging contact tracing and vaccine uptake with populations with limited English proficiency?
So I'm hearing a lot of language access pieces. So I'll use my own culture as an example. Usually there's 3 people that you never question, right? And that's the teacher, the doctor, and the priest. Whatever they tell you, this is what, you know, you're gonna move forward with. And I think it's our responsibility to create that space to have people ask their questions, because a lot of times people won't. So I think that's going to be the first thing. The arrow is pointing to us, and not to that individual. You know, when I spoke with some of the leads for contact tracing earlier today, I said, you know, unfortunately, my sense is that, you know, being interviewed or spoken to by a contact tracer means that, you know, this is punitive. And that's not the purpose of it. You know, the purpose is to find enough information to keep people healthy. However, you know, we know that the chatter sometimes isn't bad. It's like, oh, don't tell them because whatever reason. So we need to understand why people are first, we need to create the space for people to be able to share that information. And then also provide that quality language access assistance for those whose preferred language is one other than English, or who are part of the deaf and hard of hearing community, because they seem to be, there isn't as much sometimes consideration for those communities, or they're not included in the equation. And so for us to be able to present an opportunity to create that space so that folks can ask their questions, and to, you know, using your health literacy skills, you know, giving information, teach back is great. What's your understanding of, you know, what questions do you have? I mean, these are really simple that we can move forward with. I think this will be the first time that anyone is going to be doing a health literacy presentation to our contact tracers. So I see it like, you know, somebody having an ECMO procedure. You got one chance and that's it, right? And so, you know, having to be very, very careful on how I present that information. And that's one of the first things I said. I said, are we creating the space for people to be forthcoming with the information, or are they seeing this as punitive? Because nobody's going to share anything with you if they think you're going to get in trouble. Or is somebody not sharing it because they think, oh, if I tell them that, that means that they're not going to be able to go to work. And unfortunately, that person has to go to work, right? And so what are some of the reasons behind that? The linguistic piece is one, being able, if somebody does not speak the language of the individual that they're working with in contact tracing, then they need to figure out a way how to communicate. And remembering that not all communication is verbal, because I can roll my eyes or sigh, and y'all know what, you know, how I'm feeling some kind of way, right? So being mindful of that. And we can also ruin a relationship in one sentence. So being mindful of how we're saying it and the energy behind it is going to be really important, you know, English to English or otherwise. So what I'm encouraging the cadre of contact tracers here is, you know, to be mindful of the energy and their presentation. You know, this is not policing, and policing has gotten a negative term in the media as well. You know, this is to be able to get information to keep people safe. Whether or not they want to disclose, you can only do so much. And one of the first rules in, you know, social welfare is, you know, you don't work harder than your client. So trying to get information as best you can in a way that's going to be respectful, regardless of the language and regardless of the individual, is going to be really important. You know, and there can't be any judgment here. Okay, somebody tested positive. Do you know why? I mean, because if you tested positive, what would be the first thing you want people to know about you? Or how much into your business would you want people to get into? So these are some things to be mindful of when we're dealing, you know, across cultures and across languages.
So we have a couple more questions that have come in, Wilma. One was, you talked a bit about including community leaders' trusted sources as vectors for getting information disseminated, and importantly, in order for the information to be trusted. Do you have any insight or experience how this is best accomplished in geographically isolated areas? So, you know, almost all of our states have, you know, more rural or more geographically isolated areas. So is there anything you're doing in New York or anything you've seen in other places that you could recommend?
Yes, that's really interesting because, you know, people think New York State and they think like the 5 boroughs or whatever they saw in Law and Order, or I don't know, any of this stuff, right? What we're working with our Office of Rural Health right now to address some of this. And so when we're talking about rural, that's one thing. When we're talking isolation, that's another, because some of our elder community can also be isolated, right? Some of our undocumented community can also be isolated. And so if we're looking at what we're doing with our rural communities, or less population, if you will, is engaging them to see what practices have they utilized in the past or at least during the previous months, to get information out and resources out to our community and what lessons learned are there that we've had there. At one point when I was doing research in a more rural part of the state, which is Montgomery County, which is approximately, I would say, 45 minutes north of the city of Albany, and we're about 2.5 hours away from New York City, if you will. We were doing some work there with adolescent pregnancy and prevention. And what we found was that with the resources that we needed, first of all, this population, adolescents who are teen parents, have already felt that they're already functioning, or they're already operating under a stigma. And also, too, they've already been judged, right? So we needed to be very mindful on how to communicate and get information out to them. So when we first started this research project, we didn't call it a research project. We looked at all these evidence-based models. And evidence-based means that if it worked in San Francisco, California, it was going to work in Fulton, Montgomery County, which is very rural, right? And that wasn't the case. So what we did was we created our own model based on the input of some of the trusted community leaders. And those were people who ran, beauty salons. Those were people who were part of, Catholic Charities or United Way. Those were folks who helped manage the senior center, or who were the receptionists at one of the physicians' offices. Those were the folks that were trusted, and they were the ones that helped build our model. So we would probably, in this case, go back to those trusted leaders in the community, because remembering that a trusted leader doesn't have to have leader in their name or their title. Well, the community knows who they trust, and we've been fortunate to connect with folks who have been trusted. So we'll continue to use those types of models when we work with our rural communities. At the end of our research project in Fulton, Montgomery County, we started off like a really small group, like 4 or 5, teen moms, and we would say, bring your partner, bring your parents, bring whomever you need that supports you. And we offer childcare by individuals who are trusted within the community, and we're also vetted through our research project. And by the time we had moved through the project, we had 30 participants at our events, because we showed them really basic things like, did you know that the coupons that are in the newspaper you can use, those 30 cents off adds up? Because if you were 30 cents short, you'd have to be putting something back, right, when you're checking out. So we did that, and also oral health, a lot of myth versus fact. And then also, too, in a completely non-judgmental way. This is the information. This is for you to have the information. Whatever you choose to do with it, we hope that it's really helpful to you and yours. And we hope to continue a similar model when we're working in our rural areas, when we continue to work in our rural areas.
Okay, so our next question is more about interprofessionalism. So Baltimore, one of its hallmarks is that it's a very interprofessional campus with a lot of, institutionally supported interprofessional activities. In fact, the team that you're interacting with here came together as a result of funding to put together an interprofessional approach to health literacy. So one of our fellows, Dominique, asked, how do we appeal to students and professionals from other disciplines, such as law or, social work, which maybe have not been as active in health literacy, in valuing these health literacy communication principles and the need to incorporate them into this pre-professional education? Because that's really where this student team has been focused, is, trying to move all of this upstream, get health literacy as a social determinant in the educational activities in an interprofessional way. So do you have any advice for the students in terms of appealing to this interprofessional approach to health literacy?
I would look for your early adopters, because they're there. And we may not know about them. However, I found that there are folks, as many of you have in your experience with health literacy, that there is an early adopter with this, about this, and for this within these professions. I think of, I can't remember his name. He's the attorney. that was with us on the health literacy roundtable.
Oh, Chris?
Yes.
Yes, actually, yes, he's going to be speaking to the group in the spring.
Awesome. See, awesome. See, so there's, there's some, because, attorneys and surgeons just get the worst rap. They really
Dr.
do.
Gerald's a surgeon, so watch out.
See, there you go. See, right? And let me tell you, of the folks that I really enjoyed interpreting for, I mean, and not saying this just not knowing that you're a surgeon, but, I would work with our surgeons, whether they be, neurosurge, plastic surge, and, the languages was concise, clear, bam. I knew, okay, this is going to take, not as long as if I go and do, work somewhere else and, interpret somewhere else, because it was like bam, 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 done, right? And so I think that there are early adopters and champions within the various professions that can assist by providing their experience and their lens on how to move this forward within professions. I truly do. So, for example, here, when we were working with health literacy, so on one end, I would get this one group that would say, well, we really don't really, reuse that. And then I had folks within that same area say, we really need to use this. So how do we strike that balance? Because at the end of the day, we're looking at that common goal, right? How are we communicating effectively throughout the department, throughout the area, for those whom we serve? How are we doing that? And I would think that would be the lower hanging fruit. Who are the champions? Who are the adopters for health literacy, for effective communication? I mean, like our communication folks, they were just so thrilled. Yay, that we're talking about health literacy, and they had all kinds of ideas and all this. And then we had some other folks that were like, well, I don't know if we really need that. And then it turned out that, yeah, we did, and we really do. And it's necessary. It's, sometimes it's about the presentation and what that message is.
So the next question builds exactly from that. So for these early adopters, these advocates, what is the easiest thing they could do? So you've got your champions, you've got your early adopters. What's the first thing these early adopters or champions could do to make a change?
Okay, well, first of all, what kind of change do you want to make, right? I mean, how is it just within your own area? Is it interdisciplinary, so it's going to go across the entire organization?
Well, for these students, it's definitely organization-wide. So they're speaking. They can speak across all the schools.
Oh, awesome.
Yeah.
Okay. So all right. So here's well, I'll base it on our experience. This is what was helpful for us. So what we did was, we had folks from like all across the department, and then there were some folks who people think that you work in the same place, everybody knows each other. But that's not the case. People are, may have been taking a different elevator the 20 years they've been here. So what they were able to do was, one, they were able to look within their own areas and find out what resources were available. That was one of the things they did. The other thing that we did was we put together, and you all have already probably done all these steps, so you're light years ahead of where we were when I came on board. We looked at existing materials, because one thing is, it's like, directive by PowerPoint. So if there's a PowerPoint somewhere, then that means it's accurate. No. So when we looked at some of the existing resources and materials, we're like, oh, here's opportunity for enhancement. So we were able to do that. And then also we were able to update a lot of the information, share different resources, and then put those resources in places where they were available. And that was such a simple thing to do, and it really cleared the way to start moving this forward. Otherwise, we would have never even had the opportunity to do a survey across the department or even a summit. So doing some of these things like this, looking at resources and then including those resources within the actual documents and products was really helpful. So using certain techniques. So we'll use ours for example. So when we would meet with our community partners, and we would ask them, we would look at our materials and say, how are they going to, if we have to read this more than twice, is the community understanding what we're doing? Because this is, this is DOH language. So within my own department, within my own office, we needed to clean up a lot of that language. That was one thing. We had to educate our own team members here about what health literacy is. So one of the things I had asked my staff was, if somebody asks to talk about health literacy and I'm not available, who's going to be able to do it? So that was something that we needed to share, that kind of knowledge within the area. And there are opportunities at meetings to be able to share that information and do a reporting out. So that was really helpful, and that helped move things forward to continue to share that knowledge and that information. That's an easy lift. And then also too, what's very helpful was anything that we could share regarding webinars, WebExes. We've done those for the department. It's been very, very helpful to folks. They've brought examples of, how can they change language? How can they update it? That's been really helpful. Now when we're writing guidance, looking at some of this, that it's very specific to a very specific population, we're like, wait a minute, no, this needs to be active language, not, in the event of, or, something that's going to be a little bit drawn out. So one, modeling the behavior is really important. Presenting it at our meetings, that's been really important. And educating our own staff, that's been very important.
Okay. Well, we have 3 questions that have come in, and we only have about 4 minutes left. So maybe just like, if you can kind of maybe touch on each one. They're kind of big questions, but one is research. Do you have any recommendations for improving health literacy research, specifically to connect with communities? So that's kind of a big question, but if you've got a short answer about that. Another one about if there's anything, any health literacy project that you've done during the pandemic that really stands out to you, that's been the most rewarding. And then just anything more that you think faculty could do, or that the team could do to help faculty understand the importance of health literacy. I think you addressed some of that in terms of educating staff and delegating those responsibilities. But if there's anything else you think faculty could do so that they can work better with students, that's because it's frustrating for students or challenging for students if the faculty haven't made it a priority.
Okay. And I can only imagine it being frustrated because faculty is under such pressure to be able to, to perform. It's like everybody had to pivot to remote, like on a dime, and that's really hard. And then there's different levels of being technologically savvy, so that's that's also a consideration. I think for that one, I'll try to be very fast with that one regarding faculty. It would be, what exactly is the challenge with the communication? Is it the way a syllabus is being put together? Is it instruction on how to turn in an assignment? What's the situation that's needing a little bit more clarity and our opportunity for enhancement, and also presenting it in a way that is not giving the impression that you're adding to the faculty's plate. Because let me tell you, if something is presented to me that looks like it's in addition to, that's just not going to happen. I mean, it's going to happen when it happens, right? So, health literacy, you want it to get to the point where it's woven into and not a second thought. It just is part of what you do. So for now, I think at least for us, the challenge is, how do we present it in a way that it is not perceived as in addition to and one more thing for faculty to do? What are the areas that you're really looking to focus on, and then growing from there? That's one. Health literacy project, that right now what we're doing is we just received the results of our survey, because all of our data people got pulled to do our governor's daily presentations with data. So, our health literacy survey data got put on hold a little bit. So now that they have an opportunity to breathe, they were able to put our results together, and now we're in the process of starting to write. We're looking at seeing where we can looking at where we can have at least one paper published, and then also presenting a white paper so we can have that internally. So that's one of the health literacy pieces during the pandemic. I feel as if everything I do is my favorite health literacy project, because that's what's helping me keep my sanity right now. Quite honestly, that and the work involving racial and ethnic and social justice. And then the first
Research. Yeah, anything about research with the community on health literacy?
Well, it depends what kind of research you want to do, right? And so, and what community you're talking about. So if it's going to be more of, okay, we need to educate, if we want to find out why people aren't wearing masks, that one's going to be a big one. What's the purpose of the research behind it? And also too, what's the goal with doing the research right now, and how are you going to do it, right? Because it's going to take a little bit longer. For example, putting anything through an IRB process right now, staff is getting pulled all over the place. So how are you really going to be able to do something effectively and efficiently? That's one thing. However, there is opportunity. There is opportunity. We do something that's called, this office is the architect of the Voice Your Vision community listening session. And so what we'll be doing, the way we'll be researching, quote unquote, is that we'll be reaching out to the communities. We'll have a community leader reach out to their communities, which is the model that we've utilized in the past, to pull together our communities to ask them very pointed questions regarding trust, regarding dissemination of information, regarding myth versus fact, and then seeing, you know, what can we do with the outcome of those results so that we can better move forward with the resources and plans for during the pandemic. So research, I would say, make sure that, you know, you are really thinking through what you're going to do, because again, you probably have one chance to do it. And so having a community partner with you to provide that lens, because sometimes we think, oh yeah, I know that community. I used to go shopping there, I used to live there or whatever. However, if you're not perceived as really being part of that community by the community members, then guess what? You're not part of them. So seeing how you can best partner with somebody within that community and propose that research is going to be a big piece of whether or not you're going to get any kind of buy-in and therefore any kind of success.
Okay, great. Thank you so much. I know we're at the end of our time, and you've given the students and the faculty who've been able to tune in today a sense of what you've been dealing with there, you know, on the ground in New York State. So thank you so much, Wilma, for taking time out of your schedule to join us. Dr. Gerald, any last words you would like to offer here?
All right. Well, I want to thank you, first of all, for taking time out of your schedule. We're all kind of working on overtime here, so it's really appreciated that you come. Although the good news to that is, of course, you didn't have to take a plane or a train.
Yeah.
We could do it electronically, so that made it a little nicer for you and for us as well. So thank you for that. Thank you for your comments. We've got a long road ahead of us in terms of dealing with these issues, particularly in the COVID period. So thanks for your comments, and we'll see what we can implement.
Thank you very much. And with this, we will conclude this session of the President's Symposium. So thank you all for joining us today.
And thank you for having me. Stay safe.
Thank you, Dr. Bauer, for also jumping in there and being a wonderful facilitator. I appreciate that.
Yeah, my side job is as an MC.
And you did it well. Thank you so much.
Thank you, everyone.
All right, take good care.